Good evening. And for those of you who weren't over at the public health posters just now, I'm Rick Moore, Dean of College of Medicine, and this is one of our multiple events associated with Martin Luther King Day and week. And we have a remarkable speaker tonight, Dr. Adewale Troutman, who has demonstrated a lifelong commitment to social justice, human rights, health equity, and national and global health. Broad spectrum, but he has been part of it all. He was involved in the civil rights movement as a young man, and he cited the connection between that involvement in defense of his and others' civil rights with his later career spent striving to abolish inequities within our healthcare system. Dr. Troutman received his MD degree from New Jersey Medical School, a Master's in Public Health from Columbia University, a Master's in Black Studies from SUNY Albany. He's the immediate past president of the American Public Health Association and is currently professor and director of public health leadership and practice at the University of South Florida College of Medicine, College of Public Health, near the College of Medicine. He has a really remarkably varied career, including clinical emergency medicine, hospital administration, academic, and public health practice. For many years, he served as associate professor at the University of Louisville's Public Health and Information Sciences School, while also directing the Metro Louisville Department of Public Health and Wellness. While there, he's credited with founding the first Center for Health Equity in a Health Department and the creation of the Mayor's Healthy Hometown movement. He's also credited with the passage of one of the strongest anti-smoking ordinances in the United States. With all of the free time he's had in his career, he's been a special consultant to the World Health Organization in Thailand and Japan, on health assessment missions to Angola, Jamaica, Zaire, and then on training missions in India and Austria. And he serves as a member or past member or president of a remarkable series of boards, National Board of Public Health Examiners, the Academy for Health Equity, 2 U.S. Department of Health and Human Services committees, the Black Caucus of Health Workers, for which he is the past president. And the list honestly goes on so long that when I read it, I think, what have I wasted my life doing? It's like I've been in cruise control my whole life relative to this man. Clearly, his life and his career have been at the center of the struggle to eliminate injustice and oppression in the broad spectrum of our society and across the globe. And I'm honored to welcome Dr. Troutman to speak.
Good evening. Are we on? It's just I can hear now. Yeah. Thank you, Dean. I'll try it again. Good evening, everyone. Good evening. As I said during the posted session, my wife and I arrived here from Tampa, Florida, to today after having 2 flights canceled and found in fact this is one of the coldest days of the year here, so we're so happy to be a part of a record set that. Sorry. I appreciate that. Oops. So I wanted to start out this presentation. But first of all, we're very happy, with the weather being what it is, we're still very happy to be here, to have an opportunity to share some of the celebration of Martin Luther King Day with you all. I've already been very impressed with what I see from the medical students, with the commitment to integrating medical education with public health education and actually recommending, in my position, that people who are in public health need to find out more about the clinical side of medicine and be jointly educated, I believe, in the same room around the same subject matter. I think would take us a long way towards having a much healthier society. So we want to thank Tiffany Delaney, who's over, where's Tiffany? Right here, from Diversity, Inclusion, and Cultural Competency, the dean, both deans actually. And did Joanne make it? Joanne McVeigh? She did?
Oh, Joanne McVeigh.
Yeah.
Yes, from the dean's office.
From the dean's office. So when we think about Vermont, we don't get it very often. We think about maple syrup and cheddar cheese and white. That is to say that flying in on a plane, when you look out the window, you see nothing but white. It's the snow every place. Also, one of the things that you learn when you travel is that you find populations in places you didn't expect to find them, diverse populations, many of whom were refugees. So we learned about the Burmese refugees and some of the programming that you guys are doing with them. Some of the programs that students are involved in, population abuse in the elderly, alternative medicine, et cetera. So we're, again, very excited to be here to talk to you this evening about something that's very close to my heart. Coincidentally, this is a slide that we made up a long time ago. And when I saw that this was, in fact, the theme of your MLK week, I said, well, I guess we're on the right path here. The importance of this quote is that Martin Luther King is known for his activism as a civil rights leader. But lesser known is the fact that he recognized that of all the injustices, injustice to health, the most shocking and inhumane. There's one other quote that we often use, is that injustice anywhere is a threat to justice everywhere. So the rest of the introduction. This is a dated photograph. You might say from the style, but this is my family. That's my two brothers and myself. And I often want to point out that my mother, in the center of the picture, is now going to be 96 years old. Her birthday is February the 8th. We're going to celebrate her birthday within a couple of weeks. But I wanted to share with you that my mother at 90, she's 96, has had some health challenges. And recently she had a couple of episodes where she passed out. Turned out she had sick sinus syndrome and had a pacemaker put in. But while she was in the hospital, she was hallucinating and just the things that happen to seniors sometimes when they're in strange environments. And I remember talking to her, and she said, who's that in the doorway? I said, Mom, there's nobody there. I said, yeah, there's somebody right there. So I thought maybe either somebody was coming down to get her, to take her back, or she was just having a bad day. So after that session, after talking with her that day, my brothers and I got together and suggested that maybe it's time for my mother to be in an assisted living facility. So we talked to her about it, and she said initially, yes, she was. We did some research trying to find a good place for her, and called her one day about Saturday morning, about 7:30 in the morning, and say, Mom, we found a place, and I think it's time for you to think about assisted living. And she said, you know what, I changed my mind. Because Preston, that's her dude. Her dude. Preston now comes to the house 3 or 4 times a week, and he cooks and he cleans. I don't think I need assisted living. So I said, okay, Ma. I figured I'd mess with her. I said, you tell Preston, if he doesn't take care of you properly, I'm coming to the Bronx, and I'm going to kick his behind. And she said, oh, you can tell him yourself. Preston is 78. She's 96. So she's the original cougar. As for myself, I think it's sometimes important to hear people's stories. Just very, very briefly, I'm actually born not too far from here. I was born in the South Bronx, affectionately known as Fort Apache when I was in that part of the world. My mother raised the 3 of us. My father left when I was about 4 years old. But while he was in the house, we observed alcohol abuse. We observed domestic violence. Matter of fact, one of my early memories of my mother is with a black eye because of what my father had done. And my brothers and I lined up beside the door in the apartment with wooden stools that we had made for Christmas, waiting for him to come home so we could beat him up at 4 or 5 years old. We were poor. I often say we were so poor that we couldn't afford the OR at the end, so we were just po. But this is also a time growing up in the 50s and 60s where the movements really got very hot and engaged. There's the Civil Rights Movement, the Black Power Movement, the Women's Movement, the anti-war movement against Vietnam. Those younger people in the room who were not around at that point in time, it's a history lesson for you. But having lived through that era, it is something absolutely overwhelmingly powerful to guide the rest of your life. And I had no idea I'd be a physician when I was a kid growing up, because my junior high school guidance counselor told me that I should go to vocational school and be an auto mechanic. And my high school guidance counselor said, you're not college material, you should join the Air Force. And the only thing that kept me from doing that was the fact that I was a pretty good athlete and I wanted to play basketball. And the school that I was going to be sent to had a lousy basketball team. So being committed to sports was actually a good thing. And I also remember, and I would love this, my wife and I are working on a book, but driving down to Virginia with my mother one day, stopping at a Howard Johnson's restaurant because I had to go to the bathroom, frankly, and get something to eat. Going up to the front door and seeing words right across the two front doors, facilities for white only, which is an absolute shock to a 16-year-old kid who felt that he was bad enough to go in and take on the KKK or anybody else. My mother, being the wise person that she was, said, no, son, let's get in the car and keep going. You'll go to the bathroom when you get to where we're going. But the things that brought me out of that history, I did love to read. I was a pretty good athlete. I'm an African percussionist, so I play whenever I get an opportunity to play. And the notion that I could really change the world, I really believe that. And I think that many young people today have the same belief. I do believe, looking at the poster presentations, I'm sure there's some in the audience who feel you, in fact, have what it takes to change the world. And I think that that's something that we need to continue to focus on, which is a notion that the power of one is alive and well today. I just thought about some of the people who, as individuals, have done just tremendous work out of one person's will and desire to make a difference. Of course, Martin Luther King, this is the week that we're celebrating his birth. But Malcolm X, Steve Jobs, how many people have iPhones, iPads, Apple, something or other? This one guy literally changed the way we communicate throughout the world. Angela Davis, who was active in the 60s. If you look at this, there's a video clip called The Power of One, which shows an individual standing in front of a tank in Tiananmen Square. You may have seen that. How he stops the tank, and then the tank starts to turn to the left, and he moves to the left. The tank's right, he moves to the right. And I don't know how long that lasted. They didn't continue the video, but he, in fact, had an opportunity to stop a tank. We recently lost, of course, one of the real great men in the history of the world, as far as I'm concerned, Nelson Mandela. Stephen Biko was a South African physician who was murdered under the protection of the police after he was arrested in South Africa. Harvey Milk, the first openly gay politician to declare it. And then last but not least, Mother Teresa, Gandhi, and you. Each one of us has, I think, the opportunity and the power to take them with the power of one to make a dramatic difference and recognize the notion that we are connected. We've tried, I think we spend so much effort in talking about them and us, and there really is no them. It's all us. And we're absolutely intimately connected through many, many different ways. As clinicians and people who work in the field, how we've seen epidemics become pandemics spread around the world. We've seen bird flu, tsunamis in Japan, and refuse washing up on the shores of Oregon and Alaska. West Nile virus, how did it get from where it was to West Nile? I mean, to New York City, for instance, or other parts of the United States. Deepak Chopra's molecular science that looking at subatomic particles now, finding that the particles can be in the same place in two places at the same time. When you walk into a room, you breathe in the metabolites of people who are in the room. So if you walk into a room, everybody's mad and upset. You're getting mad and upset genes, and molecules spread to you. So we are all connected, and consequently, we have to live that way. Also, one of the leading philosophers of our time, who said, I have to be James Earl Jones now. We are all connected by the great circle of life. That's Mufasa for you. I guess you didn't see that. So we're not going to have a blatant partisan political discussion this evening, and I don't want to call it a lecture. Although race is involved, that's not the main function of my talk tonight. Certainly, the medical model that we are all a part of has to be looked at in a different light, I believe, these days. This is not an easy conversation, nor is it an academic exercise, and I hope that we have some time for discussion later on. Reframing is an important part of what I want to talk to you about tonight. Words are power. Words are very powerful. Framing an issue, the framing determines what the definition is, how you resolve the problem, what allies you work with, who's against you, what resources you might need because of the framing of the argument and the language that we use. There are several that are important. I'll only mention a few at an interest in time. Health versus healthcare is the most basic. Still today, if you went outside of this room and asked somebody, what is health? They're going to talk to you about doctors, medication, diagnosis, management, clinics, etc. They're not going to talk to you about the broad spectrum of health that really determines what happens to individuals and populations, which are the things that I know that you're looking at through your curriculums. housing, education, occupation. Over the last couple of weeks, we've had speeches from the Pope and the President about economic inequity and how they are connected to so many evils. In fact, many people think that the most important determinant of health, in addition to what we said a little while ago was the zip code, is the gap in income. There's a correlation between income gap and the gap in health status that many populations suffer from. We're all working around moving from individual to population health. Market justice versus social justice. My friends often say when I talk about market justice that that's an oxymoron. How can you have market justice? Well, the market is all about just us or just them, and meeting a bottom line and making a profit. So market justice, but market justice philosophy, which many people believe in, says that the benefits and the burdens of society are all based upon what the individual does. Now that means the translation to us is that, well, if you're poor, it's your fault. If you're an alcoholic, it's your fault. If you have, you don't have a good place to live, it's your fault. There's violence in your neighborhood, it's your fault. That's market justice. Social justice, as I reframe, says that no, the individual plays a role, of course, but societal factors, societal forces are dramatically important in determining what happens to the health of populations and individuals. Rights versus privileges, we'll talk about that in a minute. Creating health equity versus eliminating health disparities. Health disparities as a term was very, I think, useful for us for many, many years. As we started back in 1985 talking about minority health and the task force on black and minority health from 85, the Secretary Heckler's report. In fact, we used the word disparities after the offices of minority health started to be founded. And those disparities means that it just means differences. That's what the definition of the word is. What's happened to it is that it's been linked to populations. So it's disparities in health status and access to care in various disease entities, et cetera. But it doesn't portray the real power of the language that we need, I think, at this point. So many of us now are talking about health equity, and we'll talk about the definition in a minute, versus health disparities. So I want to give all credit to those who are using disparities to get us where we've gotten to, but it's time for us to think in a broader context, and health equity, in fact, is that context, and I'll talk to you about that in just a minute. WHO has been a leader in this belief that it's all about social justice and the rights of individuals. And this quote from the keynote address of the 7th Conference on European Ministers, WHO, that there can be no hope for the spread of freedom, democracy, and human dignity unless we treat health as a basic human right. And we still have arguments over this for some strange reason, and many people in this country are ready to accept the notion of the right to bear arms, but not the right to health. There's a disconnect there for some unknown reason. Quickly going over definitions that I'm sure we all know by now, but I wanted to just remind us of some of these, that the definition for health really talks about the presence of physical, psychological, social, economic, and spiritual well-being, not merely the absence of disease or infirmity. And my favorite definition is the one that says health is the maintenance of a harmonious balance between mind, body, and spirit, which indicates that we are this triad of existing parts that work together, and if any one of those is out of balance, we just cannot be healthy. Long definition. Don't like to put a lot of words on one slide, but I didn't want to shortchange the definition of health equity. I will point your attention to the highlighted portions of this definition, because it talks about all people, the highest attainable level of health, a focus and ongoing societal effort to address these issues, particularly for those who have experienced historical or contemporary injustice or socioeconomic disadvantage. This is the definition, the working definition that many of us use these days to talk about the health status of the United States and the populations around the world. Because health equity is both a national and a global issue, where many countries around the world are seen as the have-nots, and the Western societies are seen as the haves. There's the same connection of issues. If you're talking about the United States, in fact, looking at populations, African Americans, Native Americans, Pacific Islanders, Asian Americans, et cetera, Native Hawaiians, a group that's recently defined itself, that's a part of the definition of health equity. This is the one that sets, I think, the political landmark for us, because it says that health inequities, which is a more up-to-date way, as I said, of talking about these issues, that they're systemic, they're avoidable, they're unfair, and they're unjust. They're sustained over time and generations, and they are, in fact, beyond the control of individuals. Or what is justice? Well, justice talks about a very difficult subject for us, which is fairness. How do we determine what is fair? I often say if you have teenagers, then you have conversations about what's fair all the time, because kids often tell their parents this is not fair. It also talks about the principle of moral rightness, and equity is in the definition of justice. And then it could not just having the moral rightness, but a conformity to that rightness in action or attitude. One of the reports that came out some years ago talked about provider bias in the approach of patients, whether conscious or unconscious. Based upon this definition, you'd have to say if provider bias exists someplace, by definition that is an unjust system and needs to be addressed. Social justice is taking those basic principles and elevating them to the broadest level of society. There's equity, again, in the definition of social justice, and highlighted as an equal access to societal power, goods, and services. WHO says the same thing. World Health Organization, in their report a couple of years back, says that one of the things that we have to find a way to do is to rebalance power, money, and resources around the globe if we're ever going to have a just society. This applies to the United States as well. Human rights, we talk about this all the time, that health is a basic human right. The definition is that they are morally based and universal, belonging to all persons equally because they are human beings. And then in parentheses, the Declaration of Independence says we hold these truths to be self-evident that all men are created equal and endowed by their Creator with certain rights. And among these are life, liberty, and the pursuit of happiness. The reason I mention it is because it doesn't say health. But if you talk to constitutional lawyers who do this work all the time, they'll tell you, you can't have life, liberty, and pursue happiness without having health. So it is implied in the Declaration of Independence. It, in fact, is in the Constitution of 115 countries around the world, where the language is either medical care, health, etc., is a basic human right. WHO, sometimes we need to look someplace for the definition in writing. And WHO declaration from its Constitution, 1948, says directly the enjoyment of the highest standard of health, not just some mediocre standard, but the highest standard of health, is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social condition. So what I understand about the moving very close to a universal system of coverage here in this state is absolutely amazing. We're going to move here. I didn't tell my wife yet, but we're looking for an apartment shortly. And then from the Commonwealth Fund, ensuring access to quality, affordable health care services is not merely a matter of system reform, it's a matter of human dignity and national wellness. So again, Vermont is right in the forefront of this. Oh, sorry, Albert, didn't mean to get there. I had the privilege of sitting on Healthy People 2020 for several months while we went over this document as a Citizens Advisory Committee. What I wanted to point out from Healthy People 2020 is that for the first time in this national health plan, the words health equity are in the document. If you know Healthy People 2010, it says we're going to eliminate disparities by the year 2010. We didn't quite make that. Things are still looking pretty bleak for many populations. But we feel that focusing on health equity is the key that's going to get us to the desired goal, which is ultimate good health for the entire population. So there's my friend Albert. Albert Einstein. One of the things, he's obviously a brilliant man. One of the things he's paraphrased as saying, if we continue to do the same thing in the same way and expect a different result, we're insane. In the context of the work that we're all doing, if we continue to do the same thing in the same way, which in this context is the old model of medical care, the old model of sick care, really, not about prevention, not about population-based. If we continue to do that and expect that somehow we're going to close the gap in excess death and raise the level of health of the entire country, we are insane. It has to be done through a combined effort through population health and clinical medicine. And, it's easy for me to say that you know this because we've seen the program, we've heard about your second year. What are the second year medical students in the room? And he said, way in the back, what are you doing way up there? So he would say, you need a new direction. And we believe that new direction, that exciting direction, is in fact looking at social determinants of health as the primary focus of our efforts to improve the health of populations and to close the gap in excess death. You know, because we are all in the sciences, we love diagrams and whatnot, so we left this in our presentation. If you look in the center of this, let's see if I can get this to work. So here's the individual and some of the things that we know about the health of individuals, some of the factors, age, sex, and hereditary, et cetera. There's the individual lifestyle. And we used to teach that this was the most important element of the health of individuals, is personal behavior. That's being challenged these days with the notion that social determinants are such more vitally important beyond the lifestyle. There's social and community networking factors, and general socioeconomic culture, et cetera. So this is a diagram of the discussion of this. The upstream analysis and the upstream action. What this is a metaphor that says that if you imagine there are two people and they're standing right over there. They're standing here and they're fishing and having a great Sunday afternoon, drinking a Bud Light. No? And all of a sudden, a baby floats down the river. In shock, they look at this baby, and before they can do anything, a second baby floats down the river. So the first guy throws his fishing rod down and dives into the water to save the babies. The second guy throws his fishing rod down, but turns and starts running upstream. And the first guy calls to the second and said, "Man, yo, where are you going? I need you to help me pull the babies out the river." He says, "No, I'm going upstream to find out who's throwing the babies in the river and stop them." That's the upstream analysis that we say is the best way for us to get to the destination that we want to get to. Because downstream, the babies in the river represent the tens of thousands of people who die in excess because they are either the wrong color, the wrong language, no money in their pocket, their wrong sexual orientation, that these people, and poor housing, poor education, these are all the things that are downstream that we're trying to fix by being in the river downstream and fixing them. So we have a downstream program that says we're going to screen everybody in the country for diabetes or hypertension. But we don't find out why they have this problem, because we haven't gone upstream. Upstream is where the action is. Now, I would also tell you that we can't all go upstream to find the answers and forget downstream. A study I did in joint publication with Dr. Satcher found that we lose roughly 84,000 people a year in the African American community in excess. Shouldn't have died because of either the socioeconomic status, the neighborhood, et cetera. 84,000 people. That doesn't include Latinos, Native Americans, Pacific Islanders, Native Hawaiians, Asian Americans, poor whites. So the number could actually be somewhere over 150,000 people who die in excess every year because of some of these factors that are upstream. So we want to fix them, but we can't all go upstream because we'll lose these people continually over the next 10 or 20 years. But upstream is where we find these social determinants. Quite a daunting list when you think about socioeconomic status, occupation, education, and income, and put poverty right on top of that statement. The continued existence of racism and discrimination, housing difficulties, political power, the social gradient, and the list on the other side comes right from the World Health Organization, Solid Facts, which was published about 5 or 6 years ago, looking at things like social exclusion and work, et cetera. You'll also see on the side of this line here, the social gradient and stress. Those are probably the two most important outside of socioeconomic status of factors that determine the health of populations. We know that this is what we believe from examples around the world, that dealing with the social determinants of health may yield greater and more sustainable returns, which is absolutely what we want to see happen. So I've figured out for the next few minutes, I want to talk about a few of the social determinants of health that demonstrate to you how important they are. The first being education. And, you know, in our business, over the last couple of years, we've talked a lot about health literacy. But in fact, literacy itself is an important element of the health of populations. Education can improve by increasing health knowledge, greater employment opportunities. You know, the more education you have, the better job you have. The better job you have, the more money you make. The more money you make, the better neighborhood you're more likely to live in. And it's this kind of a cyclical element, those three elements all feeding into each other. It's linked with social and psychological factors that affect health. And we've seen in our travels at least 2 or 3 fantastic programs where they're taking this to heart and putting it into action. One being Kalamazoo, Michigan, where they have been able to find a way to elicit the support of benefactors from all over the city of Kalamazoo, to the point that they now guarantee anyone who finishes high school will guarantee a 4-year education at one of the state local colleges. Now, that varies in terms of time. So if you only went to high school for 2 years, you're not going to get 4 years out of them for the program. But the program is doing very well in increasing the academic achievement of kids who live in those neighborhoods. And we know that there's a relationship between their health and their education level. 55,000 degrees refers to a program in Louisville, Kentucky. So there are things that we've seen around the country that are important. 55,000 degrees. The city decided, after a recognition that educational attainment is extremely important in all aspects of health for populations, put together a task force committed to getting 55,000 degrees over the next short period of time. That is to say that if you dropped out of high school, we want you back getting a GED. If you have your high school, your graduation, we want you in college, community college probably. If you have your community college, we want you in four-year college, et cetera, up through the PhD level. And they're committed to 55,000 degrees. Housing. Aristotle, another famous friend of mine, along with Thomas Edison, said, "Tell me how a man died and I'll tell you where he lived." Any environmentalists here would love to follow up on that, I think. And we also talk about the built environment and the effect of housing and the built environment on the health of populations. And how's that for an unsafe, unhealthy environment? This is an apartment in the Bronx, New York, actually. This woman is putting water in this pot to feed her family. She's going to boil a chicken, probably is what it looks like. And I look at this picture every time I put the slide up and say, I wonder what the kitchen looked like if she had to come into the bathroom to get water to boil her chicken. Clearly, this is not a very healthy environment, and therefore this is going to be directly impactful on the health of the children who live in this apartment. Residential segregation, another important element of the work that we have find ways that we have to work on, which is to say that not only racial but socioeconomic residential segregation is extremely important in determining the health status of populations. On this side, this is a housing development project in Louisville, Kentucky. This is an actual photograph, and I'll tell you to look at this and tell me if this feels like a safe or a healthy environment to you. You'd probably say, no, it doesn't. The other side of the slide, this is the same neighborhood after a Hope 6 project. If you know what a Hope 6 project is, you know that it's about the federal government putting money in local communities to eliminate housing projects because of the notion of segregation of poverty. And in this instance, this old neighborhood here that had I forgot the name of this neighborhood, but this is now Park Adewale. It's very but in fact, this neighborhood now has multi-level housing. Some people have Section 8. Some have bought the house outright. Some have mortgages. And you cannot tell from one to another who's who and what's what. So they've effectively eliminated the notion of segregation by socioeconomic status and poverty in that neighborhood. They just recently got a supermarket as well, after 10 years of trying. So some of you who are doing, we stopped by one of the projects out in the lobby of nutrition. Was it Juan? Raj and Laura, if they're still here? No. The conversation about food deserts, nutrition is all connected to what this new way that we're trying to see the world of social determinants of health. Racism. So sometimes we have difficulty with this concept in this conversation, and some people have even asked me directly, said, Dr. Troutman, this is 2013. There's a black man in the White House. Why are you still talking about racism? And I have to point out that the first people of color from the African continent were brought here in roughly 1619 to the United States. From 1619 or thereabouts to 1863 by the Emancipation Proclamation. In 1865, by the end of the Civil War, racism was institutionalized in the form of slavery in the United States. That was the law of the land. From 1865 up to 1964, which is the first civil rights legislation, we had a short period of Reconstruction where things were moving in the right direction, but then a rise of the KKK, the terrorism of the Klan. Number 2 cause of lynching of men, number 2 cause of death for black men in the turn of the century was lynching. Segregation in the North, segregation in the South, the black codes, Jim Crow legislation. All these things took place over the period between 1865 and 1964. From 64 to today, 2013, my math is not very good. It's roughly about 40, who's a good mathematician? How many years? 45, 46 years. Ooh. So it's impossible to eliminate the effects of 200 plus years of racism, slavery, and institutionalized racism in this country in less than 50 years. So it's here, it's still here, and until we find a way to talk about it, it's going to stay here and continue to affect the work that we do. This is a definition from a good friend of ours named Kamar Jones, who says racism is a system of structuring opportunity and assigning value based upon how one looks. So genotype, not phenotype. Phenotype, not genotype. It unfairly disadvantages some individuals while it unfairly advantages others and saps the strength of the whole society through the waste of human resources. She also says there are 3 levels of racism: individually mediated, institutionalized, and internalized. And the way I often describe them is say that I've decided that everybody with green hair is a criminal. My decision. So whenever I see somebody with green hair, I treat them as if they're a criminal, because that's what I believe. So I get out the way, I treat them differently, whatever it is I do. That's individually mediated racism against green-haired people. Institutionalized is that, well, now I have a job with the housing authority. And it's my responsibility to write the policy for who can apply for and get an apartment in our complex. Well, you know what I'm going to say. Green-haired people do not get an apartment. That's now institutionalized, it's in the policy. So 20 years from now, somebody else comes along and looks at the policy. It's already there, so that's the way they behave. That's institutionalized. Internalized is when people with green hair decide, you know something? They're right. We are criminals. We are not worthy of trust, and therefore we're going to behave a certain way. That's internalized racism. Which one is the most insidious is very difficult to say, but they're all at play in this discussion about racism in America. And what we see is only the tip of the iceberg. You have to look down underneath the water. As you know, most of the iceberg is underneath the water. So in this discussion in context of social determinants, we see what we see on the top, but underneath is where all the real action is. There is a history, and it's certainly one that I think we all should explore. We're not going to do it now. But this is a nation of immigrants. Ethnic and health disparities have been occurring for centuries in this country. Sometimes in a small group, I ask students to tell me how long they think racism has existed in the United States. And sometimes people will say since the very inception of the nation. And I think that's basically true based upon what I've said. It goes back to at least 1619. And there's a couple of researchers at Harvard University who have actually coined a term called the slave health deficit, which take it all the way back to the initial capture and march to the coast of millions of people of African descent who died on the way to the coast and are part of this notion of differences in health and status based upon racism. Some of the things like Articles of Confederation, the Declaration of Independence, and so forth, none of those included black people, African Americans, or Native Americans in their drafting and their employment. Naturalization law of 1790, only white people could become citizens. African Americans were counted, you know this from your early history days, I'm sure, as 3/5 of a human being under the Constitution. It was a negotiation between the South and the North, but black people were not even considered an entirely human race at that particular point in time. And if you look at this long list of legislation that was passed over the years, which are clearly racist in their intent, you can see that there is an issue that we continue to have. The Chinese Exclusion Act of 1882, Native Americans granted suffrage only up to 1924, suffrage for the African American race in 1965, et cetera. So this is what we're talking about. You may have seen the history books with pictures of this, but this is the way it was for many, many years in this country. For those younger people never had to experience this. I'm glad for you, but this is what we continue. There's a continuing legacy of this notion of racial discrimination. As a matter of fact, the laws that were developed in the United States were used by the apartheid regime in South Africa to construct petty apartheid, which is an interesting parallel between those two systems. This represents the Trail of Tears, and the notion of generational trauma. Trail of Tears was the forced march of Native Americans from the East Coast all the way out to the Oklahoma territories, where literally thousands of people died en route and were buried along the side of the road. So if you talk to people in the Native American community around the country, they're going to know, they're going to remember the Trail of Tears. And sometimes we wonder, why is it that people of color don't trust the system? Why do they feel that they don't want to present to a hospital for services, or they don't want to present to a social service agency? They just don't trust the system. It has to do with a long history of generational trauma and what are called microaggressions, which things continue to happen to people today. Someone black walks into a supermarket or a store and they're followed around the store, and that generates an elevation of cortisol, which is probably problematic in terms of other systems of the body. This is a study that was published by Institute of Medicine, National Academy of Sciences. There was a substantial discussion around the existence of evidence of racial discrimination in the healthcare delivery system. And IOM took this on and put this project together, looking at literally hundreds of studies that suggested there was racial discrimination in the delivery of care. The one that probably got the most attention is what's called the Shulman chest pain study. There are 8 people in this study that were all actors. They were all dressed similarly, they all similarly articulate, and they were given scripts to present to the cameras if they were having, well, I won't say having a heart attack, but they were having cardiac issues. They were having chest pain with shortness of breath, radiation down the arm, the classic presentation of chest pain and cardiac insult. The doctors were then shown these videotapes, and the only instruction they gave them was to take a look at the videotape and tell me what you would do. Well, the right answer, the correct answer, should have been this person going to the cath lab immediately for whatever invasive surgery, invasive procedure we need to perform, because this person looks like they're having a heart attack. That was the right answer. After all the tapes were looked at and the physicians made their diagnosis and their prescription of care, all the white men were sent to the cath lab. Black males, black females, and even some white females were sent out the other door, home, with, this is a GI problem, take some Maalox and call me in the morning. The implication being those individuals who sent out the other door literally fell dead 2 blocks from the hospital or in their car driving home, because that is what they were presenting with. That's the signs and symptoms that they were presenting. The suggestion is, and this is in the conclusion of the study, is that provider bias played a part in what happened to these individuals. The provider bias, whether it's conscious or unconscious, determined the fate of those individuals. And from this study, just the highlighted portion said bias, stereotyping, and prejudice, and clinical uncertainty on the part of healthcare providers may contribute to racial and ethnic disparities in healthcare. I'd go a little step further and I said it does contribute to it, but this is a study that was published by IOM. So here's the solution for staying healthy, a social determinants approach. Don't be poor. If you can, stop. If you can't, try not to be poor for too long. Don't have poor parents. Don't live in a poor neighborhood. Own a car, but use only for weekend outings and walk to work. Practice not losing your job and don't become unemployed. Don't be illiterate. Avoid social isolation and try not to be a part of a socially marginalized group. So that's the prescription for, I'm just kidding right there, right? Leadership is important in this, and sometimes when I talk to physicians, they say, well, what do I do? I'm concerned about these issues, and what do I do? Well, exert your leadership. Whatever community, when you graduate, those students up in the back there, when you graduate and finish your residency, you're going to be stationed in a community, and you're going to be respected, and people are going to look at you as a source of community commitment and leadership. And you have an opportunity to help to shape the future versions of government, of distribution of power. You certainly have an opportunity to look at yourself in terms of the potential of any bias that might be present in the way you do your job, and make sure that you found a way to eliminate that from your persona. An opportunity to be about equity and justice is what's available to you as you move through the system. Now, those who are already out, my fellow colleagues on faculty, you all have the opportunity to continue to build friendship and leadership amongst the students who come through the system, and continue to work on finding ways that we educate ourselves together, the academic community partnerships, which I read about here in this institution, in the state, and movement building. So the leadership is something that each one of us can cling on to and make a dramatic difference in this country. But there has to be a movement around social justice and health equity behind that. So these are some attributes of, classical attributes of leadership. Being a visionary. Everything that exists today was a vision in some person's mind before that. This computer was a vision, this desk was a vision. How many of us have ever visualized health equity or social justice for everybody? We talk about it, we give it lip service a lot, but how many people have actually sat down and said, I wonder what this would look like? I'm going to visualize what this is going to look like, and I'm going to turn my life into a commitment to social justice and human rights. Expressing your ideas to various audiences, garnering support and commanding resources to do the things that you think you want to do based upon your vision, developing and shepherding your ideas into successful policy programs and services. Part of leadership is also getting people aligned with your vision and finding ways to get people on the same page and finding ways to get the resources that you need. Knowledge of the big picture of public health is very important. I'll tell you that as a family physician, I spent 17 years in practice, most of it in emergency medicine, but there's nothing more personally satisfying than being an individual clinician and taking care of, in this case, a woman and her child. I diagnosed her pregnancy. I followed her through the entire prenatal period. I delivered her baby. I then saw her baby and her in their postnatal visits. And that is absolutely amazing. Or being in the emergency department and someone comes in chest pain, shortness of breath, and you literally do the right thing and save their life and get them to the ICU, CCU, so they can be, And they come back and they see you later on and say, Doc, thank you very much. Very, very few things that can top that in terms of its effect on you as an individual. But if you want to make a real difference in the world, you need population address, you need population health, you need public health as a vehicle to do that. Why do I say that? Well, take the example of seatbelts. Some of the younger people in the back probably don't remember this, but I do. There was a time when cars did not have seatbelts. It was about 150 years ago, But someone came along and from a public health intervention said that we need to find a way to save people's lives from traumatic injuries from motor vehicle accidents. So we're going to write a law that requires that every vehicle built in the United States has a seatbelt in it. That was great. Then they had to pass another law that said you got to wear the thing. And then another law to say that we can stop you for nothing more than looking for seatbelts, not just accidentally coming across somebody who stopped for running a red light and find they don't have the seatbelt on. That was policy. The policy that's now being debated in the United States, the Affordable Care Act, is a policy initiative to bring universal coverage to everybody in the United States, at least make sure that everyone has some form of coverage. That's a policy initiative. You can literally, in Louisville, Kentucky, the policy we passed about smoking in public places affected some 23,000 businesses in our area that no longer smoke. You can't have smoking in those businesses. That's a policy initiative that can literally save thousands and thousands and more than thousands of lives. So policy, understanding the broader picture, and thinking about the individual versus collective differences that you can make is a part of what you need to think about as you move forward in your career. Effective negotiation, mediation, and conflict resolution skills. These are all attributes of effective leadership. And of course, strong interpersonal communication skills. So, we talk a lot about the theory, but there are examples of putting health equity issues and work into the real world. In Louisville, Kentucky, we started Center for Health Equity, which is the first of a local health department in the United States. Its focus was on capacity building and system change, not providing another access for health education, et cetera. Alameda County in California literally created within the health department a unit whose responsibility was to look at social and economic change as a public health intervention. So what a radical idea, a public health department having a group inside of it that talks about social and economic change. King County, Boston Health Department. The Boston Health Department decided to take on racism as its primary focus, and now have policies and procedures in place against anti-racism in city government, with resources from the mayor to make those to turn those into reality. And in Portland, Oregon, where we saw GIS mapping resources that were absolutely amazing. I know some of you are doing this work may have some exposure to GIS mapping, but individuals from communities can pull up GIS maps to determine what their communities look like when it comes to things like housing, education, access to good nutrition, food deserts, et cetera, to build responses to changing their plight. You've heard about this. Some of you have probably seen it already, and I coincidentally wearing the same blue shirt today that I did. I do have more than one blue shirt, though. Just a reminder for those who have not seen, please you should just take a look at unnatural causes as a part of your curriculum, a part of your education, understanding social determinants of health. So I said before that this was about building a movement, and I believe the civil rights movement did not go far enough in terms of where it was heading. We have an opportunity to complete the process. Building a movement, I just wanted to focus on the top piece. Throughout history, social movements have brought about the most significant changes for racial, economic, and gender justice, and I'm placing this squarely in the context of this notion about building a movement. This is what we're talking about. An iconic photograph of literally tens of thousands of people of all colors, all political beliefs, all shades, all sizes, demanding rights, demanding jobs, demanding justice. And I would ask you, if you were in this demonstration, what would your placard say? What would you be organizing for? What would you be marching for in terms of what's good for the populations of the United States? Health and all policies is this kind of the current discussion of change that we're focusing on, which is to say that public health needs to work in conjunction with every other type agency in the government or in the society to bring about change. Public health does not have the authority to draft housing policy or transportation policy, but in your work as clinicians, you need to know that the reason that person missed their appointment was because the bus system was not working and they couldn't get to your clinic, or the way that the reason that people are eating Mickey D's all the time is because there's no healthy food outlets in their neighborhoods, and that's going to affect your diagnosis and your management and treatment when they come in to see you. So this is directly related to your work as clinicians. Transportation, school administrators, land use decision makers, parks and rec, the police, which is not up here, public safety, et cetera, are all parts of what health and all policies looks like. The Affordable Care Act, you've been following the news as much as I have. What's good about the Affordable Care Act is that it has lots of resources for prevention, lots of money for resources for prevention. The Public Prevention Council, where 19 cabinet secretaries sit together and discuss common problems. An opportunity to address social determinants of health, which can be very valuable and powerful for us. And I offer this to you for those who are thinking, we just passed Christmas. World Peace is asking a lot for Christmas. I'd settle for universal health care. And of course, we know that's going to happen here in Vermont. That's why we're moving here. So hopefully you got something out of this brief discussion about social determinants of health and social justice, et cetera. Maybe a new perspective that you haven't had in the past, and maybe generate a national discussion on justice, or discussion here, a further discussion here at this medical school on these issues of justice and human rights, and that you leave with some level of inspiration. So what can we all do today? This is for each person in the room. Recognize the importance of health inequities, first of all. Increase your personal knowledge in the policy process. Incorporate practice in your individual roles. That's social determinants of health. Become an ambassador for health equity and social justice. Remember the power of one is real, and know that the risks are worth taking. So we talk about risk in this business. Risk is an extremely important element of leadership, and if we're going to get any place, it's going to be about taking a risk. So I'm going to ask you to take a risk with me right now, and take a deep breath, and just close your eyes for a minute. I'm going to talk to you for a second. So take a deep breath if you would. Just trust me a little bit. Take a deep breath. And visualize health equity as I share this piece with you. To laugh is to risk appearing a fool. To weep is to risk appearing sentimental. To reach out for another is to risk involvement. To expose your feelings is to risk exposing your true self. To place your ideas, your dreams before the crowd is to risk their loss. To love is to risk not being loved in return. To live is to risk dying. To hope is to risk despair. To try is to risk failure. But risks must be taken because the greatest hazard in life is to risk nothing. The person who risks nothing, does nothing, has nothing, and is nothing. He may avoid sorrow, suffering, but he can't simply learn, feel, change, grow, love, or live. Chained by his certitude, he is a slave. He has forfeited his freedom. The only person who is free. Open your eyes and meet my other favorite philosopher. I like to close with Spock, because one of the things he's noted to say in one of the episodes of the movies was, the needs of the many outweigh the needs of the few or the one. So I'll leave you with that thought, and live long and prosper. Oh, questions and answers. I'm told do we have time for Q&A? Yeah. We have time for questions and answers if there are a few people who want to ask a question, comment. Yes, no? Yes, sir.
So you talked early on about the connection with the income differences in the country, and I read a piece recently by an individual who was a hedge fund trader on the New York Stock Exchange and found himself complaining about a one-year bonus of $3 million not being big enough when he was in his early 30s. But he seems to have seen the light, and he came to realize that some of his bosses were so far over the top in terms of becoming addicted to wealth, as he said, that he's changed his directions, and he's actually getting involved in some nonprofit work around developing sustainable food systems. What I'm wondering is, aside from that individual, who I think is somewhat unusual, how do we reach that ever-shrinking population of people who are so much invested in the wealth that they can't see the needs of the men?
Yeah, I don't have the answer. I wish I did. I know that there are people who have greater minds than mine. Jeffrey Sachs and who've written about the end of poverty and a roadmap to finding ways to eliminate poverty in the world. This is a global approach, not just the United Nations approach. How do we change the basic belief that some people have, that is the market justice philosophy, that it's all about the individual, and if you don't make it, it's your fault. Society has nothing to do with that. I think we have to find that's the root of finding a way to address the issue. The fact that WHO and others have recognized that economic inequity is a major problem and cannot continue to exist without major issues around the globe. I think it's important we've gotten that far. But I don't have the specific answer. I wish I did. It's about changing the way we see the world and changing what we do in that world. And on all levels, not just the guy who got a $3 million bonus, but somebody who's living on subsistence income in the south side of Chicago. How do we find ways to encourage people to be more organized and be about systems change and policy development, and taking their own neighborhoods under control, and making sure that it fits the needs of what they've been expressed. Opportunity neighborhoods, we have good housing, good education, good job development, safety, transportation, etc. Yes, sir.
Just a great discussion, by the way.
Thank you.
I'm originally from Detroit, Michigan, and I'm sure you guys have heard the news of our city just declared bankruptcy. We're currently recovering from a financial crisis. Being from there, I know firsthand that access to healthcare and access to good schools and good housing is not as common as for people who aren't very wealthy. And so, in rebuilding Detroit, how do you suggest we improve our public health in the city?
In the city of Detroit? Tough question.
It is.
Yeah,
so I'm asking you.
I think frequently the answers can come from the population themselves. We often think that we can go into an area and make a change and do something that is the right thing for the community. But your philosophy here in this college, in the school, is that community comes first. Community first. Whether it's a research project or policy development or initiative to get people more engaged in what's going on in their community. Community first. So I would say that the challenge is how do we stimulate people in communities around the country who are suffering and on the margins to become more active in the policy process and demand change and demand equitable opportunity in all areas of their lives, including health, as one small area. The few words I mentioned about health and all policies is an example of what can be done with a focus that looks at all the potential areas of problem in a community and looks at policy development through public health collaboration, but with transportation, education, et cetera. So that neighborhood where there's nothing but fast food restaurants and no supermarket, you need a policy decision that says you cannot build another fast food outlet in this neighborhood, or you can't open another liquor store in this neighborhood, or you must have achieved a certain level of excellence in your educational institutions by a certain point in time. And of course, the challenge is the people who are the elected officials need to understand that if you don't do this, you're not going to survive. We're going to organize, and one of the things that I found people in public health is that we don't organize very effectively. We have a tendency to be very altruistic, which is cool. You got to be that, but there's more that has to happen. We have to be finding the hard work of organizing, and sometimes putting yourself at risk, which is one of the reasons I close with this particular piece, is what has to happen. You're welcome. Yes.
So I recently had a conversation with my friend's dad. We were kind of at odds on healthcare, and he was saying basically what you were saying, that some people don't, not everyone believes that healthcare should be like a fundamental right.
Yeah.
And I was kind of like dumbfounded at the moment, and I didn't think of any kind of cool counter. But after that, I was kind of thinking, I anticipated an argument for a conversation like that I might have in the future. And that's like, where's the line drawn for free healthcare? Like, because with the shift towards integrated medicine in the field today, like massage, acupuncture, myofascial reliefs, like where I'm kind of anticipating, like if I have the conversation again, maybe someone will bring that up, sort of, and that might be a possible counter-argument. Can anyone coming off the street and get a massage for free, or where do you suggest the line be drawn, or is there a line to be drawn?
So I'm not quite sure what you're asking about the line.
For universal health care.
Yes.
What constitutes healthcare, I guess? Because, like I said, you have some people could argue that massage is part of your healthcare, or that acupuncture is part of your healthcare.
Yeah.
So where do you think?
There is, I think there's a fair amount of research in some of the integrative medical treatments, regimens. There's some suggestion that hypnosis has value. There's some suggestion that acupuncture has value, particularly for pain relief, certain kinds of pain relief. As you know from your question, there's a whole plethora of modalities, iridology and foot reflexology and a whole lot. I think at this point in time, as far as that part of the world is concerned, we need to focus on what science has shown has some value. If we just go completely open door policy for all forms of integrative medicine, I think we're making a big mistake. But at the same time, we need more research in integrative medicine to see where, in fact, the line needs to be drawn. What can we prove has value and doesn't? But we need to approach it without blinders, without Western-oriented blinders, which say nothing else is value except Western medical care. And I think we can agree on that. There are things that come from other communities and other cultures that have value when it comes to health. That's part of. I guess I tried to answer your question best I could. Did I get to the core of your?
I think so. So you're saying like that originally, like at this point in time, just to get our foot in the door, we should at least address kind of like universal health care for what's been proven, like you said, more like Western medicine.
Right. At this point in time, but with more research required to find out if there are other modalities that have value. I'll tell you straight up. When I had back problems and sciatica, I went to an acupuncturist. But I also did nutrition and physical therapy. I said, I'm going to do everything because I'm not going to let myself, just continue to have this pain. Anybody on this side of the room? Yes.
Hi. Without going into great detail, I think we all pretty much agree in this country we have pretty fragmented systems of care. We're just starting to integrate primary care with mental health and addictions care. My question to you would be, how do you think fragmented care or lack of integrated care on a systems level as well as maybe on a provider level contributes to health disparities. I mean,
Yeah.
we have individuals today that are getting addictions treatment in isolated trailers, unmarked, that they're segregated for their addictions, and segregated mental health treatment, and segregated. How do you think that contributes to health inequity?
Yeah, I think it absolutely does. As a matter of fact, there's some data that looks at the cost in human life as a result of people not being covered under any policy whatsoever. We do not have a system of health care in this country. We, in fact, have a fragmented system of sick care, where inequities are flourishing and prevention is an afterthought. So it definitely is a major contributor to the ongoing existence of health inequities in society, and to the extent that we can increase cooperation, collaboration, et cetera. I thought somebody fell down over here. To that extent, I think we can be successful in finding ways to address the many facets of our system into one. And one of the things that we should be doing is looking more closely at other systems and finding ways to be open to what they have to offer. So as APHA president, I went to Taiwan this past year, which has achieved 99% coverage of its entire population, and 98% of them have smart cards. They've even conquered the electronic medical record issue with a smart card and a smart card reader in the provider's office. So when you come in to be seen, you swipe your card, the clinician swipes his or her card, and the entire history and medical treatment, the previous visits, diagnosis, problems, all comes up on the screen, just like that. So it can be done. Yes?
I'm from Taiwan myself.
Oh, hi.
I live in New York City now. When I went to the hospital when I was really young, I used to wait like a long time to see a doctor, and like there would always be confusion about like, oh, where's my medical record, blah, blah, blah. And when I went back 2 summers ago, it was really, really fast. I was even seeing like a few specialists in a day. So,
Yeah,
I
thank
just
you.
wanted to say that.
That's great. Up in the back.
There's a lot of talk out there about how big the problems are that we're talking about. And sometimes our students, medical students, and I presume other people in training, hear this and might feel that it seems negative. Like people have particularly even physicians or current health providers are negative about the present and negative about the future. And they hear this. And sometimes I've heard them speak with me with a sense of discouragement. Should I be discouraged about the future? And I think what we try and do here, and many people do, is not say that there are not problems, but that we have so much talent and so much ability that we can really transform what's wrong. And I guess I wondered what your thoughts are in terms of all the people we're educating and what to focus on to keep your eye on the prize and where you're going and to stay optimistic.
Yeah, I absolutely believe that looking at this issue as an issue of human rights and social justice is the way to go. I think that to me is the beacon, that's the shining light that's off in the distance that I stand on and focus my attention on, and keeps me optimistic. Because I have to be optimistic. There's no other choice. Otherwise, I don't even deal with the otherwise. You have to continue to be optimistic. I think that the students, all the greatest movements in history have been involved with students in one way or another. Leadership or major supportive elements to make sure that the movement went in the right direction. I think the same should be true today. That the people in this room who are students ought to be the guiding lights, or the hope for tomorrows, the ones that say this is, in fact, does not have to be the way it is. It can be changed. The definition I used for inequity, systemic, unfair, unjust, also unnatural, meaning the existence of inequities that we see today came about as a result of what we did as human beings. And if we did it, we can undo it, and we can put something else in its place that has a guarantee for people to live their lives out to the full extent in the healthiest way that they can. So I remain optimistic.
I'm with Dr. Troutman and Cindy's past and the Troutman Group. but I think in answer to your question, and to end sort of on a positive note, what we saw of the poster projects of these students, to me, is that light, because they definitely stand on the shoulders of others who've gone before and working with the community to literally have solutions. I mean, talking to that young lady, I don't know, they're not here, but we talked to another young lady, Liz, in elder care. They were really excited about the fact that they made an impact in their project. So I think that, to me, what you're doing right here in Vermont, at the University of Vermont, is exactly where that positive light is, that they are exacting a change every day. And in this project, I think it's huge. And that's where the positivity comes from the students in this room that are just so excited about the work that they're doing and the future ahead of them, that they have an opportunity to do some amazing things outside of just your typical medical model. They're doing some things. So I think there's a lot of positive out there.
I'm told we have time for one more question. Yes.
Me?
Yes.
Can you speak to how sort of the lack of diversity in the healthcare workforce relative to the population's diversity is contributing to healthcare inequities?
Yeah, it goes to the core of some of the work around race and racism, and people who are struggling because of the language difficulty or where they were born. And so the notion that there's a difference between people based upon genetics, first of all, we know it's just not true. And the Human Genome Project made it very clear there's no genetic marker for race. It's more about the way you look and that others' interpretation of who you are. There's no question about the fact that racism and ethnicism, if there's such a word, play a part in the existence of health inequities. Just the study that I highlighted, the Shulman chest pain study. What's the explanation for the fact that all the African Americans in this study were sent out the door with non-cardiac diagnosis and probably fell down and died? There's no question about the fact that inequities contributes to the number of people who die in excess based upon race, ethnicity, et cetera. I don't think there's any argument to that nowadays. It's to the extent is how do we address that? How do we change that? How do we find out what provider bias actually looks like? Why is it that certain populations have a more difficult time to get medications than others? Certain kinds of medication. Why is it that there's a difference in diagnosis for depression and schizophrenia based upon the way you look, based upon race? So there's no doubt about the fact that it's alive and well and directly contributes to it. Is how do we go upstream and look at it as an upstream factor of downstream result that we need to find a way to address.
Were you talking about workforce, i.e. sort of more people of color within the workforce?
Well, not necessarily just maybe more of a broader distinction of diversity to include economic diversity. I think that the inequities are, as a lot of the slideshow pointed out, that a lot of inequity is related to poverty. But in the healthcare system, I don't see a lot of the workforce having, at least of those people who work in roles where they have decision-making authority and have influence, they, I think, disproportionately come from lower, or those people come from higher socioeconomic status, and maybe have trouble with relating to the barriers that poverty creates to health.
I was going to talk about pipelining. I don't know if I'm talking about we've done some work with different organizations around pipelining, which is attracting younger folks into the areas of public health and medicine, and how do you do that at an earlier age, and working with middle schools and high schools and getting folks interested in either public health or medicine, because you're exactly right. Sometimes you go into places and the folks making the decision aren't as culturally competent to work with that population, because I think you do feel more at ease if you're Burmese and you're actually seeing a Burmese physician or an attendant or somebody. So you feel more at ease. And I don't know about people of other folks of color or culture, that's what you feel comfortable with, but how do we get them there? And I think we've got to start educating students younger. So we've actually worked in a consulting capacity to get students who are we worked with an organization where they were trying to get students involved in internships over the summer. So I don't know how many students you can get involved in what's going on with the presentations even today, or get involved with the university, or using that as a mentor relationship. So the kids are getting excited. Kids of color and kids of different ethnic diversity are getting interested in medicine, because that's the only way that you're going to see more of that. I mean, even here, as we look around, it's great to see that there are some students from different cultures, and that's good. We have, and hopefully there's some African Americans. Saw one or two, but that's what's important, is literally recruiting a more diverse environment to ensure that those students are coming up and are out there so that we can see them in the workforce.
I think there's good evidence that more than suggests that students, when they finish their training, are more likely to go back to the communities that they know, and more likely to be providers to that population. So to put it in concrete terms, you're more likely to get an African American physician to go back to Central Harlem to practice than you are to have a student who comes from Scarsdale, that's the New York references, to go back to that same community. And the sense that African American is more likely to understand the culture of the neighborhood that he or she is working in is a part of what we believe is true. I think it's some evidence that suggests that it has. So continuing to the downside, I should say, is that the percentage of African American physicians in practice today is about the same as it was 100 years ago. So despite the efforts that we put together to increase the recruitment of that particular population has not been very successful over time. So it remains an issue. And I think it's a part of the overall solution that we're trying to find here. Okay, thank you very much.